Welcome back to the second of two endocrine blocks in pharmacotherapeutics. Here we'll talk about all of many of the remaining endocrine issues for which there is some pharmacotherapy outside of diabetes mellitus. We'll talk first off about thyroid states, both hypo and hyperthyroidism. We'll talk just briefly about pituitary conditions, but as a primary care provider, you need to be familiar with them, but also know when to defer some of these cases to an endocrinologist. We'll also spend a little bit of time talking about adrenal function, and we really talk about this multiple times throughout the curriculum, in that there are a lot of prednisone-like drugs that we'll use for multiple conditions, and so we introduce this concept throughout the curriculum also in dermatology and in pulmonology in particular. So let's first focus a bit on thyroid function. If we look overall at the role of the pituitary as it relates to thyroid, the pituitary secretes thyroid-stimulating hormone you can see this on this graphic on the far right, which stimulates the thyroid gland to release thyroxine. So pathophysiologically, or physiologically at least, not in the pathologic state, we see T3 and T4 formed in the thyroid, and they actually serve as a feedback loop to affect thyroid-releasing hormone from the hypothalamus to the pituitary, or suppressing that, and also suppressing pituitary secretion of thyroid-stimulating hormone. And so for most patients, this feedback loop works well. Most often, the situation that we look at is that when this feedback situation is working and in place, we'll look at levels of thyroid-stimulating hormone mostly, occasionally thyroid-releasing hormone, to establish whether or not someone is in a hyper or hypothyroid state in conjunction with a T3 or T4 level. That usually would indicate that the problem is in the thyroid gland itself, and that's the majority of cases. We do, however, see times where the problem is not the thyroid, but it's above the thyroid, either in the hypothalamus or more commonly in the pituitary, to which we may have either a lot of secretion or a little secretion of TSH. And so whether or not what's going on with TSH may have little to do with the thyroid gland itself providing adequate feedback, just that it doesn't trigger that feedback. So it might be, for example, a pituitary adenoma that secretes thyroid-stimulating hormone that releases ultimate amounts of T3 and T4. Now, as a pharmacist, I can't go through a curriculum without occasionally having a chemical structure. But I try to limit those chemical structures for you. But here's a case where you look at T3 and T4, and you see that they are virtually identical molecules with the exception of the number of iodine atoms on those molecules. And the left, T3 has 3 iodine, where T4 has 4 iodine atoms in the molecule. Physiologically, T4 and about 20% of T3 are produced by the thyroid. Most of T3 is actually produced by the degradation of T4 in tissues, and really T3 is more physiologically, pharmacologically active than T4. So let's first look at hyperthyroid states. A number of different things we think about here, but first let's look at Graves' disease, or toxic diffuse goiter. Considered an autoimmune condition where the thyroid stimulating antibodies mimic TSH and therefore stimulate T3 and T4. We could also have pituitary adenomas that produce excessive amounts of TSH. We could have a toxic adenoma, a nodule in the thyroid that's autonomous of the pituitary and TSH. Other conditions are Plummer's disease, a toxic multinodular goiter. There is also a viral-induced condition, a painful subacute thyroiditis. And then there are drugs that also can affect thyroid function. Thyroid supplementation clearly can, and amiodarone is associated with that as well, partly because amiodarone has iodine molecules, atoms in the molecule. In hypothyroidism, the diagnosis is usually made by looking at a T4 and a TSH. And most of the time in hypothyroidism, what you'd expect to see is an elevated T4 or free T4. That's almost universally the case. But you may or may not see a suppressed TSH depending on whether or not the situation is affected by a defect somewhere, whether it's pituitary focused or whether it's thyroid gland focused itself. Also, other tests that you look at are radioactive iodide uptake and thyroid-related antibodies. Presentation for folks with hyperthyroidism, typically you'll see weight loss, increased appetite, heat intolerance. Sometimes you'll see a goiter. You might see more fine hair development. Most concerning is probably tachyarrhythmias, particularly AFib. And typically when you see somebody with AFib, we almost always will get a T4 and a TSH to rule out hyperthyroidism that could be triggering the AFib. You also will find many patients will present with this anxiety, insomnia, nervousness. Women may have menstrual disturbances. There also is commonly seen sweating and warm skin. And in Graves' disease, the other things you'll see are exophthalmos, bulging eyes, basically related to eyelids, retraction, and pretemal myxedema. We'll talk about that in a little bit. Our goals of therapy in hyperthyroidism certainly are helping with their symptom management, improving their quality of life. But really, one of the urgent issues or semi-urgent issues we need to look at is the cardiovascular risks that patients will have, particularly as it relates to potential structural changes and the arrhythmias and the risk for sudden cardiac death. So the tachyarrhythmias are problematic. Often we're going to, in the short term, if that is problematic, use beta blockers just to blunt that tachyarrhythmic effect. And that's pretty common. One of the concerns for uncontrolled hyperthyroidism is bone demineralization and the risk for fractures. That's particularly true in older women who have a pre-existing diminished bone density, but that could be with any patient. But you want to be aware of that. And our other goal is to make sure that, as part of that assessment and minimize symptoms, improve quality of life, reduce risks, is that we're also going to shoot for a normalization of T4 and TSH levels. So when we're looking at therapeutically managing hyperthyroidism, most patients are candidates for ablative therapy. These are particularly patients with serious disease, Graves' disease, toxic nodules, or a multinodular goiter. And that's done usually with a surgical resection and or radioactive iodine. Complications of that, though, is that sometimes we overshoot our intervention and a patient actually becomes hypothyroid, requiring long-term or lifelong levothyroxine as a patient with hypothyroidism would do. That's not really, it's a pretty easy thing to manage. It's a risk associated with intervention, but it's important that we do manage the hyperthyroidism because of the consequences of the risks associated with it. Who's a candidate for the drug therapy that we have? Well, let's first say that drug therapy is somewhat limited in how effective it is, and it's really, for the most part, really a short-term stopgap approach for patients. Typically, we'll use anti-thyroid drug therapy for patients who are waiting ablative therapy, patients who are poor surgical risks, if they failed ablative therapy, or if their disease is mild. So we do use them. Most often it's short-term. Sometimes it's longer-term. The therapies we use, the drug therapies we use for treating hyperthyroidism, they will inhibit thyroid hormone synthesis. It may take a few weeks, up to 6 weeks, before we see the benefit that we would expect to see. And patients may need longer-term therapy. Hopefully they are going to also be evaluated for ablative therapy of some kind. The two agents you'll see are methimazole and propylthiouracil. And We'll also look at, in addition to our goal of inhibiting thyroid hormone synthesis, we'll look at controlling the symptoms of hyperthyroidism, particularly cardiovascular, for which we almost universally, particularly in patients who have serious tachyarrhythmias with hyperthyroidism, will use beta blockers. So our therapies are for reducing synthesis of T3, T4. The oldest therapy, the one that's been around probably the longest, is propylthiouracil, or PTU. It's typically dosed 300 milligrams a day, can be initially loaded up to 900 a day, and given orally every 8 hours. The risks with it is that, among other things, it's hepatotoxic, and because of that, we're a little more concerned with its use these days and really becomes the second-line therapy. We do monitor ongoing patients, though. Their liver function tests, certainly because of hepatotoxicity, but also the TSH, T3, and T4. And you want to try to get those in a normal range while the patient is becoming less or not asymptomatic. Methimazole is the preferred agent we'll see used when you need drug therapy. Also prevents synthesis of T4 and T3, and its dose is usually 15 milligrams a day, but can be higher than that. Again, given every 8 hours. We monitor the same things, although the risk for hepatotoxicity is less, rendering this as a more appropriate first-line agent when drug therapy is indicated. Beta blockers, typically we're going to look at non-selective beta blockers, usually propranolol and nadolol, blocking the adrenergic effects of thyroid function. It may also serve to block some conversion to T3 as well. That effect is a little more debated. Its efficacy is that it blunts palpitation and tachyarrhythmias, tremors, and anxiety. And really, the patient who's going to be the candidate for this most are folks with tachyarrhythmias, particularly heart rates above 90. Other things that could be used instead of beta blockers, sometimes you'll see either a calcium channel blocker like diltiazem or clonidine therapy used. And I think in part you're going to select which agent makes sense based on comorbidity. So, for example, if someone has wheezing and asthma, COPD, we probably don't want to use a non-selective beta blocker, then clonidine or diltiazem makes sense. If you've got somebody who has another indication for clonidine or diltiazem, then those again may be first-line therapies. Sometimes you'll also see in hypothyroid states use of iodine or iodide, and these work to release stored thyroid hormone and sometimes used to reduce the size of a goiter in the gland before surgery. There are different iodine solutions available. There's Lugol solution, there's SSKI, supersaturated solution of potassium iodine, and there's just potassium iodine alone. Some patients may have a hypersensitivity effect. They get this metallic taste. Sometimes it's local irritation in the oral area, and its use can affect the reuptake of radioactive iodine. So typically, if some folks are on this short term, particularly if they have a goiter, you'll see that we will often recommend holding the iodine or the iodide solution for 3 to 5 days before there's candidates for radioactive iodide. There are also patients who have subclinical hypothyroidism. Typically, they have a low TSH and maybe a low T4. This might be seen in older patients with AFib, and so you kind of want to get evaluation here by a endocrinologist to assess what next steps are. What is most concerning, though, is thyroid storm, where the hypothyroidism is out of control. This is potentially life-threatening. You'll have patients who present with fever, severe tachyarrhythmias, vomiting, dehydration, coma, tachypnea, and delirium. And in this case, we're going to use either propylthiouracil or methimazole. Either one could probably be used. But propylthiouracil probably has more sort of historical data for its use. Iodine therapy, beta blockers, acetaminophen as an antipyretic, and many times you'll see corticosteroid added to that mix as well. Now let's talk a bit about hypothyroidism. Hypothyroidism, we'll classify this based on a couple of different conditions. First, Hashimoto's disease, autoimmune basis, and seen more often in women than in men. Sometimes it's iatrogenic, or in the case, for example, in hypothyroidism, as we alluded to, we've overshot our ablative therapy, and they end up with hypothyroidism. Sometimes it's an iodine deficiency. In North America, that's much less common now, in part because most of the salt formulations we now use, a salt that's available on the market, is iodinized. But keep in mind that if folks now are, many people who use salt are often looking at Himalayan salt or some other natural form of salt that's not iodinated. And as such, unless you eat seafood, you may become iodine deficient. Now, folks who eat seafood typically have enough iodine. That's not usually an issue. But where this historically was a problem, and when salt got iodinized 50, 80 years ago, particularly was in the Midwest where people may not have had a lot of salt-based seafood, and so their iodine content was lower in their diet. Other causes of hypothyroidism could be pituitary insufficiency. There's also drug-induced hypothyroidism. Amiodarone sometimes can cause that, either hyper or hypothyroidism. A drug that commonly causes hypothyroidism is lithium. And so patients who are on lithium will typically look at getting their thyroid function assessment done. And if they do have hypothyroidism while they're on lithium, it's pretty easy for us just to supplement that with levothyroxine. We'll talk about that in a minute. The diagnosis of hypothyroidism typically is a low free T4. Most often you will see an elevated TSH trying to stimulate the T4 to produce more the thyroid gland, to produce more T4. But if it is a central etiology, then that is, you're not going to see the TSH particularly elevated if the pituitary can't release thyroid stimulating hormone. Many times you'll also assess for thyroid antibodies, and there's a recommendation for screening patients for hypothyroidism for women over the age of 60 years. We also would look at thyroid function tests, assessments done, for example, for patients who have symptoms that could mimic hypothyroidism. For example, the most common one is depression. So we'd want to kind of make sure that that someone is euthyroid when we are managing other conditions that mimic hypothyroidism. The presentation of hypothyroidism varies, but many patients will talk about in cold tolerance and dry skin. Many times they'll have fatigue, lethargy, weakness that gets sometimes mimicked for depression or some other condition. They may have weight gain. They may have bradycardias. Their reflexes may be slow. Their skin and hair may have more of a coarse texture to it. They may have some periorbital swelling. Women may have menstrual disturbances, and there may be a goiter in a sense in response to increase the thyroid gland to produce more T3 and T4, but that doesn't really work. The goals of therapy in hypothyroidism: minimizing symptoms, and also long-term issues, particularly myxedema. We'll talk about that in a minute, myxedema coma, which is very serious, but also heart failure risk is a concern. And again, in heart failure patients, we're going to look typically at thyroid function test assessments as well. We're also going to look at getting those T4 and TSH levels normalized. The hypothyroidism management, most often for 95+% of patients, really the only drug we really need is levothyroxine. It is synthetic T4. Typically, we start with a dose for a younger, healthy adult of something like 1.5 micrograms per kilo per day. But if they're over the age of 50 or so, we may start at 50 mics per day. And if they have existing cardiac disease or they're older, much lower than that, 12.5 or 25 mics per day, and then titrating it. Hypothyroidism management with levothyroxine is best that we are consistent with our levothyroxine dosing, that we use the same product. Ideally, it should be dosed on an empty stomach in the morning or at bedtime 4 hours after the last meal. So 30 minutes before breakfast or at bedtime after the last meal. And we want to make sure it's dosed apart from other drugs, particularly divalent and trivalent cations like calcium salts, iron, antacids, that kind of thing. We're going to titrate, usually every 4 to 8 weeks, we're going to titrate it based on both the symptoms response for the patient, but also the TSH and the T4 levels. And usually if a woman is pregnant and has hypothyroidism, we often find that during their pregnancy they require more levothyroxine, and then after delivery that needs to come back down to their pre-pregnancy dosing. We also worry about overshooting with levothyroxine, and so you could end up with hyperthyroidism, cardiac risk, cardiac effects, particularly arrhythmias, and also, like you'd see with hyperthyroidism, a risk for fractures and bone demineralization. There are a few alternatives to levothyroxine. None of these are recommended by any of the major recommendation bodies in endocrinology, but they are sometimes seen, used, and off in different places. One is synthetic T3 liathionine or cytomel. It's stable, it's well absorbed, but it has to be dosed classically twice daily. That's really problematic for patients, and there's really no need in that T4 is actually synthesized or converted to T3 in the body. There's also a synthetic mix of T4 and T3 in a 4-to-1 ratio that's stable and predictable, but it's expensive and it's probably really unnecessary. Other historical alternatives, and you'll sometimes see patients use some of these, particularly is the thyroid USP, or what used to be called Armour's thyroid. This is a naturally sourced product derived from hog, beef, or sheep thyroid gland. The hormone content varies, but where I've seen patients use this product typically are if they are really wanting a non-synthetic, a natural product. There's really, to my knowledge, no real advantage of this product. It's not recommended by standard compendium for use. There's more variation among response, but it's the alternative for someone who would absolutely refuse getting synthetic levothyroxine for some reason. And then the other issues, thyroglobulin is an older product that I'll tell you honestly I haven't seen used as well. In hypothyroidism, we are worried about a number of conditions. Most concerning to us is myxedema coma, which is life-threatening with a really high mortality rate, and it can be precipitated by other medical conditions, trauma, infection, heart failure, or even over-sedation. Patients will present with an altered mental status, might even look like delirium, but they more often will have more of a sedative quality to it. They could have diastolic hypertension, hypothermia, hypoventilation, and our management is aggressive intravenous levothyroxine. When we use levothyroxine for myxedema coma, we're going to load them with a big dose of levothyroxine and then use a lower dose every day thereafter. Sometimes, though, you'll see in the hospital setting for someone who's NPO, they may actually get IV levothyroxine, and typically, if that's the case, most often what you'll see use levothyroxine has a fairly long half-life. If it's just a day or two without their oral levothyroxine and they're otherwise stable patients, they don't have myxedema coma, you might be able to get by with just holding the oral levothyroxine. But if it's a couple of days and they need their levothyroxine, they're still NPO, we can use IV in place of the oral. The issue is that when you're using IV levothyroxine in an otherwise stable patient, in lieu of their oral dose at home, you need to give their dose about a half to a third of the dose IV that you gave orally, because levothyroxine's bioavailability is orally is less than the IV formulation. You also want to look for somebody who presents with myxedema coma to see if they have a concurrent infection, which is often what's triggering it, and give broad spectrum emergent empiric coverage until that gets in control. And many times you will also get a cortisol levels and might consider giving hydrocortisone as well. All right, as we move on, let's look at other pituitary issues, particularly as it relates to pituitary function. And as we briefly alluded to and just started to talk about, The pituitary will certainly stimulate a number of hormones, including thyroid-stimulating hormone, but also adrenocorticotropic hormone affecting the adrenal cortex, growth hormone affecting the liver for somatotropins. And then we'll talk more in women's health, but here somewhat as well about prolactin, and then follicle-stimulating luteinizing hormones that are more appropriate in men's and women's health discussion. So in the pituitary gland, we think of some of these different anterior pituitary hormones and their primary functions. There's growth hormone, there's adrenocorticotropic hormone. We've already talked about thyroid-stimulating hormone, prolactin, follicle-stimulating hormone, and luteinizing hormone. And this table sort of differentiates where they are, what effects that they have. Let's now talk about a problem where there might be a problem with excessive growth hormones secreting pituitary tumors or acromegaly. And this is a presentation where a patient may have excessive sweating, joint pain, coarsening of facial features, an increased hand volume size, shoe size. They could present with hypertension, heart disease, cardiomyopathy, sleep apnea, and present with glycemic loss of glycemic control. And typically we're going to diagnose this with an oral glucose tolerance test and determine whether or not there's a suppression of growth hormone or not. The goals in acromegaly management are to reduce growth hormone and insulin-like growth factor type 1 concentrations, to decrease mortality risk and improve clinical symptoms. And typically you're going to see a surgical intervention as the management. Drug therapy has really minimal role here. Typically it could be used as a stopgap until surgery can happen. You might see in this case the use of dopamine agonists like bromocriptine. You might see octreotide used, or you might see a growth hormone receptor antagonist used as well. But these are infrequently used. Acromegaly itself is not all that commonly observed in primary care, but you want to be aware that these stopgap measures may happen. If someone is at risk for acromegaly, they are most likely going to be seen, and this is going to be mostly managed by their endocrinologist. Hyperprolactinemia, it can be caused by a pituitary tumor. Interestingly, there are a number of drugs that also will increase secretion of prolactin. This is particularly the antipsychotics, some degree the opioids, calcium channel blockers, and antidepressants can do that as well. You'll also see patients in renal failure sometimes present with hyperprolactinemia, sometimes hyperthyroidism, they'll present with this, and women certainly who are breastfeeding will present with elevated prolactin levels as well. It may present in women with amenorrhea or anovulation, infertility, sometimes unwanted hair growth and acne worsen as well. For men, it may present with decreased libido or erectile dysfunction. More often, you'll see gynecomastia and reduced muscle mass. And sort of universal in many patients might be these vague symptoms of headache, maybe visual changes or bone loss. Our treatment of choice, again, is going to be a surgical resection of a tumor if that's the cause. If it's drug-induced, you're going to stop the drug that's known to be offending. And occasionally dopamine agonists, again, could be used as well. But most often that's a stopgap measure until surgical resection occurs. For patients who have a growth hormone deficiency, typically this would present with reduced concentrations after and a challenge typically with insulin or clonidine, or maybe a growth hormone releasing hormone challenge. And most often this is going to be identified in family practice or in pediatrics. And delayed growth and short stature is a common presentation on the growth curve. You'll see these folks often at the lower quartile. They may also present with central obesity, immaturity, and facial prominence of the forehead as well. And so this is typically looked at in usually late childhood or early adolescence. Our treatment of choice is recombinant growth factor, somatotropin. it's dosed subcutaneously or IM daily, or there's a long-acting formulation every 2 to 4 weeks. That's really more commonly observed and commonly used, and it's associated with some joint pain. As far as adrenal gland disorders go, important for us to sort of step back and just think about all the things that the adrenal gland does that we think of in the zona glomerulosa on the outer side. You see the reticular activating, the renin activating system affecting aldosterone secretion and salt and water accumulation. And we've talked a bit about that in the cardiovascular block, for example, when we talk about the aldosterone blocking drug like spironolactone, or we look at how we blunt some of the effects with agents that either affect angiotensinogen to angiotensin, the ACE inhibitors, or the angiotensin receptor blockers. We also have the androgen effects of testosterone and estradiol. We'll speak more about those when we get to the block for men's and women's health. And what we'll focus here on primarily is cortisol secretion, which we've also spoken about earlier in the curriculum. So as we look at adrenocorticotropic hormone, this really controls the synthesis of adrenocortical hormones from cholesterol. And cortisol is derived from cholesterol, as are the androgens and the estrogens. We're going to look at actually administering adrenocorticotropic hormone for patients with adrenal insufficiency to stimulate the steroidogenesis and release of cortisol. Many times, though, in place of ACTH, that assumes that you've got an adrenal gland that can make enough cortisol, for example. More commonly, what you're going to give for folks who have reduced cortisol levels and the risk for Addisonian crisis is to give hydrocortisone itself, which really closely mimics cortisol. The actions of adrenocorticotropic hormone, typically the hypothalamus releases corticotropic releasing hormone to the pituitary, which releases adrenocorticotropic hormone, stimulating the adrenal gland to release cortisol, which has certainly its anti-inflammatory properties, affects gluconeogenesis, and affects protein breakdown. We spoke other places in the curriculum as well, but here we'll talk about mineralocorticoid effects of cortisol. They're the aldosterone-like effects of cortisol. They are resulting in increased sodium reabsorption in the distal tubule. What you'll end up seeing is edema and fluid retention, hypertension, and a relative effect on increasing potassium secretion or reducing serum potassium levels. The glucocorticoid effects are multiple, and to sort of reiterate what we discussed on the curriculum, we expect metabolic effects here. We see an increase in hepatic gluconeogenesis. We see a distribution or a change in lipid or fat distribution. You'll see a decrease in the peripheral glucose uptake, leading to loss in glycemic control. This is particularly true in folks with a predisposition or have diabetes. And you'll also see that fat redistribution often will have a face will look a little more rounded, a moon-like face, and maybe have a fat deposit on the back, which looks like a buffalo hump type presentation. The central nervous system effects of high levels of corticosteroids include sometimes a little bit of euphoria, mood change, behavior changes, excitability, sometimes irritability. But in higher doses of corticosteroids we give, or in very high levels of cortisol, you can see frank psychosis as well. And some of the indirect effects might be like loss of glycemic control, which we talk about a lot in the diabetes block, for example, and in blood pressure effects as well as neurotransmitter regulation. We also worry about long-term glucocorticoid bone effects, particularly when we give prednisone-like drugs longer term. We see a decrease in bone formation, decrease in sex hormone secretion, particularly estrogens, that help with bone density as well. We see decreased calcium absorption and decreased change in reabsorption of calcium, all those ultimately leading to bone remodeling and leading to increased risk for osteoporosis. And bone density loss can be pretty significant. For somebody on prednisone for a year, 20 milligrams or so of prednisone per year, someone can lose up to a third of their bone density, and that really increases their risk for fractures. We also look at the issue for the glucocorticoid effects. Classically, what you'll expect to see for cortisol levels is that for folks who have a classic sleep-wake cycle of awake during the day, asleep at night, you would expect that their cortisol levels will be highest in the morning and lower in the afternoon, where aldosterone levels really shouldn't change much throughout the day. The cortisol diurnal variation is problematic for patients, for example, who work the night shift. And certainly a lot of folks who work in healthcare work the night shift. And they'll describe to you these who work the night shift of just kind of not really getting in sync. And part of it is their sleep cycle. Part of it is maybe melatonin levels and lots of other things. But part of it is probably the cortisol secretion is also a bit out of whack. And so that's problematic and has its toll for patients as well. When we give glucocorticoids routinely for most folks who have a sleep-wake cycle that is sleep-night, awake day, we will give their prednisone or their corticosteroids if we're giving them prednisone. If it's a once-a-day dosing, we'll give it in the morning typically. For other patients, typically it probably makes sense for everybody to just give it in the morning, whether or not they work the night shift or not, just as a routine process, because they may be coming on or off night shift. The only advantage you might say is if that somebody really has a consistent awake at night, asleep every day process and not going back and forth, then maybe there's a role for taking their prednisone when they wake up for their normal day cycle. The important, I think, for you to differentiate the corticosteroids among which ones have a lot of mineralocorticoid activity or glucocorticoid activity, and their duration of action. So cortisol is sort of 50-50, as is hydrocortisone. So if someone has adrenal insufficiency, for example, it's most common we will give them hydrocortisone to mimic the cortisol. Methylprednisolone and prednisolone all have about 10 to 15% or so of mineralocorticoid, and the rest is glucocorticoid. And dexamethasone has no mineralocorticoid effect. So dexamethasone is the agent we'll use when we want to avoid fluid retention in patients, particularly cerebral edema. But keep in mind that it will not have a beneficial, dexamethasone won't help or be ideal for patients with adrenal insufficiency where you want some mineralocorticoid effect to hold on to salt and water. There is fludrocortisone, which we occasionally use for folks with severe refractory orthostatic hypotension because it will cause more salt and water accumulation. That's usually reserved for patients who don't have heart failure, who have significant orthostatic hypotension after we've ruled out drug-induced and gotten the drugs off and tried everything else, and they're at high risk for falls. But that's pretty limited who's a candidate for fludrocortisone. We've alluded to the multiple administration of glucocorticoids throughout the year. We use inhaled products as well as the oral and parenteral products in pulmonology. Primarily, we use the topical products and occasionally the parenteral or oral products in dermatology as well. And then we'll also look at inhaled nasal steroids in situations of allergic rhinitis. Maybe we'll look at even one of the corticosteroids to reduce inflammation, for example, for someone who might have nasal polyps when they're at risk for rhinosinusitis, where nasal polyps and irritation is a problem. The adverse effects of glucocorticoids, we've already spoken about this throughout both this block and throughout the curriculum. You'll see often increased appetite and edema, risk for infection, wound healing impairment, osteoporosis and effects on calcium balance, You may see hypertension as a function of the mineralocorticoid effects. You'll see potential for psychosis in high doses, particularly peptic ulcers, perhaps euphoria. And the big issue we'll see here we're most concerned about is the risk for glycemic control, loss of glycemic control in a patient with diabetes. There are a number of drug interactions for folks who are on corticosteroids. Particularly, you want to be careful about enzyme-inducing or enzyme-inhibiting drugs that will affect someone's basal corticosteroid level. And for folks who are on long-term prednisone, for example, that is a problem because if you have an enzyme-inducing drug for somebody who's on prednisone who's not secreting cortisol themselves, you can actually throw them in an Addisonian type state. So you really do want to check drug interactions for folks who are on long-term prednisone. There are other things that impact absorption of corticosteroids. Thankfully, we don't use cholestyramine much in acids, not all that common. But then there's some other interactions listed here. Just basically, I'd encourage you to check a drug interaction check when you're using corticosteroids. We are aware of and concerned for the hypothalamic pituitary adrenal axis suppression with the use of corticosteroids, the relative ability, loss of ability of the hypothalamic pituitary system to produce cortisol, and so you want to be aware of that and be concerned about that as a risk or an issue for therapy. So as we think about HPA suppression, you want to think about it being a risk for patients who are on prednisone for usually more than 2 weeks, particularly doses above 5 or 10 milligrams a day of prednisone. And you really want to be aware that making sure those folks don't stop their prednisone cold turkey. They'll need to be tapered. And you want to, they may also be candidates for a medical alert bracelet or some other, maybe on their cell phone device, on their home screen, information about them being on long-term prednisone. There is a potential risk for peptic ulcer disease aggravation with prednisone. The data is somewhat conflicting. Certainly nothing like the extent we see with a nonsteroidal. On rare occasions, when this is an issue for patients, they may be candidates for acid suppression, but that's pretty uncommon that that's really needed. The psychiatric effects we typically will see, we grade them as class 1, 2, 3, or 4, but we see these with high-dose corticosteroids. Where you're going to really worry about this most often is a patient with an underlying mental health history or who has post-traumatic stress disorder with high-dose methylprednisolone. In acute care setting, we see this not infrequently, and so you want to be aware of that. And what you may need to do is to rethink whether or not you need that much corticosteroid, see if you can manage with less corticosteroid. And you also want to probably call in psych, but they may need antipsychotic therapy as well. The psychiatric effects usually when they occur really happen early on in therapy. They're almost always dose-related. They've been most associated with hydrocortisone, prednisone, and dexamethasone, but truth be told, those are the 3 most common agents we'll use, so you want to be aware of that. And typically, you'll see that the way we'll see them is managing them by reducing the dose when we can, as soon as we can, and hopefully things will resolve, or in serious cases using an antipsychotic until you get the doses down. Rarely there's a concern for sudden cardiac death with high-dose IV methylprednisolone, and so when you have to administer it quickly, particularly that's a situation where you give a gram or more in a trauma patient who you want to reduce swelling in the spinal cord, and so that reduction in swelling is critical to reduce sequelae of trauma and reduce the risk for paralysis. Those are major concerns, so you do want to give the prednisone quickly. In that case, you'd probably want to make sure that at the same time you've got an EKG running and you're running electrolyte, you're looking at electrolyte panels to make sure their mag and calcium and potassium are all where you want them. Therapeutically, as we allude to throughout the curriculum, we use corticosteroids a lot, most often in pulmonary conditions and topically in derm, but then a lot of other conditions you'll see them used as well. So too much corticosteroid, we worry about Cushing's syndrome, and this is could be either related to adrenocorticotropic hormone, or it could be because we've given a patient too much prednisone. And they'll present with elevated cortisol levels, usually central obesity, facial rounding, peripheral obesity, and fat accumulation. They may have myopathies, may have osteoporosis. They often will have a loss of glycemic control. Women will often have changes in menstrual cycle, maybe hair growth, and hypertension. The therapeutic interventions here, if it's drug-induced, we want to do what we can to reduce the corticosteroid. If it's a tumor, you want to have it surgically addressed and removed. And if you need to inhibit adrenocorticotropic hormone secretion, we might use a somatostatin analog, or you might look at inhibiting cortisol synthesis with ketoconazole or mitotane or something like that. Most often when you're in this situation, you're going to be pulling in endocrinology service to help guide that intervention. But the first step you take is to identify if they're on a corticosteroid, can you taper that, recognizing it, and then getting a full, more appropriate workup, particularly if it's a surgical resection for a tumor. In hyperaldosteronism, this can be either related to bilateral adrenal hyperplasia, or it could be related to an adenoma, and this could be elevated aldosterone-renin ratio is typically seen. You might see hypernatremia, hypokalemia, hypomagnesemia, and glucose intolerance. Patient may also present with hypertension, headache, polydipsia, polyuria, and our drug of choice is going to be, as you would probably guess, spironolactone. And so that's going to be our first line drug therapy when we're treating it. You also want to look at, if it's an adenoma, that you get that addressed appropriately and surgically. For hyperplasia, more often what you'll see used is a spironolactone therapy. For Addisonian crisis or Addison's disease with adrenal insufficiency, you want to look at whether it's autoimmune, whether there's an infection or an adrenal infarction. You'll see a drop in cortisol and aldosterone and androgen levels. It could be related to exogenous corticosteroids, which then stop in the state, or it could be someone's on chronic prednisone, but their stress level goes up and their cortisol requirement is higher than that prednisone dose gives them. And so we can look at a rapid corticotropin stimulation test to look at that. Patients often will present with hyperpigmentation, almost a bronzing look of the skin. They often have weight loss, dehydration, hyponatremia, hyperkalemia, and an elevated BUN. Our treatment is to replace cortisol, usually with hydrocortisone with 2/3 in the morning and 1/3 in the evening. You could consider some of these other corticosteroids as well. Most often, though, not dexamethasone, because it's virtually all glucocorticoid and not a lot of mineralocorticoid activity. So let's look now at antidiuretic hormone. Antidiuretic hormone acts on the kidney, affecting the reabsorption of water, and a deficiency of ADH produces hypothalamic diabetes insipidus. This affects the collecting ducts and their ability to be permeable to water, resulting in the effects of impacting water reabsorption. And it basically, the issues we see here with antidiuretic hormone is normally produced within the cells, in the neurosecretory cells of the hypothalamus, and they're regulated. The regulation of release is by the hypothalamus. So when we see a an effect where either there's too little or too much ADH secretion, we'll either see too little is diabetes insipidus, and too much antidiuretic hormone is known as a syndrome of inappropriate secretion of ADH. So antidiuretic hormone itself, there are a number of preparations when it needs to get replaced. Vasopressin or desmopressin or lipressin all can be used to treat it. Desmopressin is probably the easiest to use because it's an inhaled form as well as other formulations as well. And there's a nasal inhaled form that's used for many cases of diabetes insipidus. Adverse effects with it is when you have somebody with diabetes insipidus for which you're replacing their antidiuretic hormone, you can end up with too much water accumulation and water intoxication with cardiovascular effects, particularly heart failure. And so you want to be aware of not overshooting that. So for diabetes insipidus, decreased production of ADH, it can have different etiologies. There's a neurogenic cause, which could be secondary to trauma or neoplasm, could be genetically related, or it could be idiopathic. And there's a nephrogenic cause, which is also genetic or acquired. And in nephrogenic diabetes insipidus, there are drugs that can cause that. Lithium most commonly. Less commonly, you'll see drugs used like amphotericin B, foscarnet, or cidofovir, which are all used by ID services in serious immunosuppressed patients. You can also have polycystic kidney disease or renal obstruction that causes a decreased production or a decreased amount of antidiuretic hormone. And you could also see patients with hypercalcemia or hypokalemia also present that way. The diagnosis for diabetes insipidus is when urine volume is greater than 3 liters per day and a low urine osmolality in response to fluid restriction. The treatment of choice is for central diabetes insipidus is intranasal desmopressin. For nephrogenic, you can stop the offending drug if it's drug-induced. We sometimes will use thiazide diuretics. The concern is that we talked briefly about nephrogenic diabetes insipidus with, for example, lithium. The problem with using a thiazide diuretic or sodium restriction is that you'll reabsorb more lithium. So you need to be kind of careful with that in lithium management when you have diabetes insipidus in lithium, because you probably will need to reduce the dose of lithium at the same time. The syndrome of inappropriate ADH secretion is kind of the opposite of that. What you'll see is a excessive vasopressin release with hyponatremia. And many times this is drug-induced. The drug that I think in practice I see this most often associated with is carbamazepine or Tegretol. But you can also see with the antipsychotics, vasopressin, and rarely with the nonsteroidals. There are also conditions associated with SIADH. Those include certain cancers, some neurologic conditions, particularly head trauma, brain abscess, or meningitis, and a CVA. Pulmonary, sometimes you'll see with pneumonias, also other infections, pulmonary infections, and sometimes with new protein deficiency states. Our first line of management for SIADH is, if you can remove the offending drug, then do that. Alternately, fluid restriction is what we'll look at. And many patients, for example, for whom, for example, carbamazepine or Tegretol has worked for them for their seizure or their psych condition or their neuropathic pain, the issue when you see SIADH is to try to reduce their free water intake. But in more moderate or severe cases, you might require a saline replacement, a urea or a vasopressin antagonist. The vasopressin antagonists, they work. We have conivaptan and tolvaptan, conivaptan as an IV formulation, tolvaptan as an oral, and they'll work. They are treatments for hyponatremia associated with SIADH. The issue is that they're relatively expensive, and we have alternatives, and the alternative that is making huge inroads in the use of in the management of hyponatremia in patients with SIADH is urea. And so oral urea probably works as well. Here's a study that looked at that. And so oral urea therapy is probably as effective as the Vaptans are, much less expensive, better tolerated in many patients. Here's more data for comparing oral urea to Vaptans, and I'm not going to go into the detail of this. Suffice to say that they're pretty much almost interchangeable. So the data indicate that when they looked at them for managing hyponatremia in patients with SIADH, and again, it's a pretty small study, but for a long period of time, the urea therapy worked probably as well as the Vaptans and is become really a intervention of choice. Finally, the last thing, oxytocin, we'll talk more about in women's health, is produced by the neurosecretory cells of the hypothalamus and is an agent that, among other things, promotes uterine contractions during labor and stimulation of milk ejection during breastfeeding. Okay, so a couple of drugs that we think you should probably have familiarity with dose and endocrine in this block that we presented, certainly prednisone and levothyroxine. These are very common drugs you will see in